So the categories, just to review, that we talked about for heart disease include vascular, valvular, electrophysiological, and that's what we're going to talk about now, and heart failure. So, and they can all lead to each other. So cardiac arrhythmias can lead to heart failure. And um, cardiac arrhythmias are electrical conduction disorders of the heart. So I want you to be able to define arrhythmias and their clinical significance. Identify the major types of arrhythmias, but I don't expect you to know gory detail. Just the major categories, if that makes sense. We'll talk about it. Recognize the symptoms and complications of arrhythmias, understanding treatment approaches, and applying that knowledge to your PTA practice. So arrhythmias or dysrhythmias are problems that occur in generating and conducting electrical impulses in the heart, and they result in abnormal heart rhythms. There's some of them that are just sort of random and don't have a long-term effect, and some of them do have a long-term effect. So if you recall, our normal adult heart rate is 60 to 100 beats per minute, and the electrical impulses originate in the sinoatrial node in the right atrium. Impulses travel through the atria to the atrioventricular node to the ventricles. And coordinated contraction ensures effective blood pumping. So if the heart were to all contract at once, it wouldn't go through sequentially like it's supposed to. So atria contract, they relax, then the ventricles contract, they relax, the atria contract, they relax, then the ventricles contract, they relax. And that keeps the blood going in the right direction at the right speed. So if you have issues where some other part of the heart just decides to send out an electrical signal, that could result in an arrhythmia. So, understanding arrhythmia is important for monitoring patient safety during exercise, recognizing symptoms that require immediate medical attention, and modifying the treatment based on the patient's cardiac limitations. So, premature contractions are one type of arrhythmia. There are premature atrial contractions and premature ventricular contractions. Both of them are pretty benign in healthy people. It feels like fluttering or a skipped beat. Um, and it shows up different on an EKG because of the different parts of the EKG that coincide with the atrial contraction, the ventricular contraction. So common causes of premature contractions are too much caffeine. Did you have like a whole pot of coffee? That could cause it. Potassium imbalance, stress, exercise, or other cardiac conditions. So if somebody says they feel like their heart fluttered or skipped a beat, ask them how much coffee they drank today or energy drinks. That's another thing people drink a lot of. Stress levels or what's going on in their life. Kind of figure out if there's something more going on. But generally, premature contractions are considered to be harmless in otherwise healthy people. So supraventricular arrhythmias. I mean, it's above the ventricles, so it means it's in the atria. I just call them that. They cause fast heart rates or tachycardia, and they're generated in the atria or the atrioventricular node. There are several different types, and I don't expect you to know all of them, but we do know from when we talked about strokes that atrial fibrillation can lead to blood clotting, and that can lead to a stroke or a myocardial infarction if the atria sends out a clot and it happens to end up in the right place. Um, Common symptoms to watch for any of these arrhythmias is a rapid heart rate or tachycardia, palpitations, which the person will report to you, shortness of breath, dizziness or fainting, syncope, or chest discomfort. So just know that the without normal contraction in the atria, the ventricles fail to fill, so less blood gets pumped out to the heart, and that's what causes the shortness of breath and the dizziness, and probably the chest discomfort too. And that's the thing that leads to other issues. So atrial fibrillation is a potentially serious condition, and it's the most common serious arrhythmia that requires medical attention. So, the two serious complications are the risk of stroke because of the slowed blood flow and pooling of blood in the atria can cause clot formation, and the heart can throw off a clot and send it up to the brain. Heart failure because of inadequate pumping and the blood backs up into the lungs and the periphery. So atrial fibrillation has serious complications, and it can be associated with other things, hypertension, coronary artery disease, etc. So AFib is pretty common. They usually have people on blood thinners. There is a surgical procedure that's called a Watchman that they basically it's a little cap that they put. There's a little blurb in the right atrium that is a place where a lot of clots form, and they put that little cap over that so to smooth out the inside of the atrium a little bit more. Kind of interesting. That's a pretty new procedure. Other supraventricular arrhythmias, I'm not going to go through every one of these, but um, they're just the different types of supraventricular arrhythmias. AFib is definitely the most common. Ventricular arrhythmias are where electrical disruptions occur in the ventricles. The ventricles are the heart's main pumping chambers, and so ventricular arrhythmia can be life-threatening. Common causes are heart attack because if the blood doesn't get to the left ventricle, like say the left coronary artery is blocked and the left ventricle can't pump out blood, the heart is not doing its job and that can kill you. It's not good. And ventricular tachycardia is and ventricular fibrillation, those are the most dangerous arrhythmias. So coronary artery, they're caused by coronary artery disease. They can be caused by heart failure. They can be caused by other heart conditions. So, like I said, the different types of heart conditions, they can all lead to each other, or they can be standalone. So ventricular tachycardia is the fast ventricular contraction rate, and ventricular fibrillation is where it's so fast that you're not getting out any appreciable amount of blood. So, ventricular tachycardia, fast, regular heartbeat. Usually it's short. If you have short episodes that last for seconds, it's not dangerous. If you have longer episodes, it can be very dangerous because it can progress to ventricular fibrillation. And that's where the ventricles don't really even contract, they just sort of quiver and they're unable to adequately eject blood. It occurs during heart attack and cardiac events because if the left ventricle is affected by the heart attack, then it loses the ability to pump blood and the heart loses its blood supply. It requires immediate defibrillation and can lead to sudden cardiac death. So immediate defibrillation is one of the best interventions that people can have. So I'm always happy when I'm out in the world and I see AEDs, automatic external defibrillators, because you could save somebody's life with that thing. Does everybody know where the AED is in the Pierce lab and the Bellingham lab? I do. Next time you're there, look for them. Know where your AEDs are. So, bradyarrhythmia, also known as bradycardia, the heart beats more slowly than normal, less than 60 beats per minute in most adults. It's normal with a very fit, athletic individual. One time I was in an EMT class with a guy who was a cross-country ski racer, and his heart rate was like 45 beats per minute, just because his heart was so dang efficient. And it was really hard to take his blood pressure because there was so much space between heartbeats. You had to really let the air out slowly. Somebody with a really well-conditioned heart who's out there, doing the cardio every day might have bradycardia. Lower resting heart rates are expected when you have healthy bradycardia. When it's pathological, if you have vertigo or hypotension or syncope, these all indicate decreased blood flow to the brain. So that's when bradycardia is an issue, when you don't want that. So following a heart attack, or if you have a potassium imbalance, our potassium has to be in a pretty close range. And if it's too high or too low, it can cause arrhythmias. Hypothyroidism can also cause bradycardia. Um, Medications that are used are beta blockers, calcium channel blockers, anti-arrhythmia medications, and digoxin. So some cardiac medications limit abnormal heart rate increase or limit normal heart rate increase during exercise. And so we have to teach our patients to use a rate of perceived exertion instead of the heart rate to monitor their exercise intensity. So we're going to talk more about the medications in a short lecture coming up. And so I'm not going to dwell on them here. So treatment for arrhythmias depends on the severity. A lot of the mild ones require no treatment. If it's an emergency, defibrillation is the treatment. For life-threatening arrhythmias like ventricular fibrillation, you need electrical shock to restore the normal rhythm so your heart will work, and immediate intervention is required. So look for those AEDs the next time you're in lab. I know where they are, so you've got to tell me when we get together again. Um, a lot of different medications might be used to correct arrhythmias or to maintain a normal rhythm. You also might need a surgical intervention like the Watchman that I was talking about. That's a relatively new one. I was just talking with a cardiologist with that recently, and he was all excited about it. They like their new interventions. Cardiac ablation destroys a small amount of cardiac tissue, but it blocks unwanted electrical pathways. So a lot of times cardiac arrhythmias result spontaneously from the heart just forming new pathways just because it feels like it spontaneously. So cardiac ablation can be helpful for supraventricular arrhythmias. So the atrial arrhythmias are more commonly treated with cardiac ablation. Artificial pacemaker, particularly for bradycardia, when normal conduction routes are blocked, you get a surgically implanted pacemaker, and basically the pacemaker waits and to see if your heart's sinoatrial node is going to fire, and if it doesn't, then it fires. It says, I'll try to let you do it, but then if you can't do it, I'm going to help. So people who have a pacemaker in, their heart rate is normally about 64 beats per minute. That's considered the normal sinus rhythm with a pacemaker because it's a little slower than average because the pacemaker waits to see if the heart's going to do it before it butts right in and does it. There's also an indwelling cardiac defibrillator if you're have it defibrillates you if it detects an abnormal rhythm. And they usually test you with an external one first to see if it helps. And if it does, they'll implant the device. So you're going to stop treatment if you have new or worsening chest pain, severe palpitations, syncope or near syncope. That probably goes without saying, huh? Extreme shortness of breath or the signs of a stroke. So stroke is an atrial fibrillation potential complication. So if you're having neurological signs, stop treatment. Um, if somebody has a known arrhythmia or has had recent cardiac events or is on multiple cardiac medications or has a history of syncope, you want to be super careful with what you do with them in PT. So exercise for arrhythmias, use the rate of perceived exertion for patients on cardiac medications, monitor not just for heart rate, but monitor them for their symptoms. This is the sort of funny scale that I was talking about. One is a sleep in bed. Two is casual walk to the fridge. Three is brisk walk to the mall or ultra walking pace. Four is recovery run. Five is base building. You see that. And then 10 is running for your life from a bear. Nine is I think I might barf. So I found that somewhere online. I just thought it was cute. So you're going to document the patient-specific arrhythmia type. You're going to say, here's their heart rate. Patient states that they are being treated for atrial fibrillation, blah, blah, blah. That's their specific medications that affect the heart rate, and they are on a particular medication, which is probably in their medical record anyway. Their baseline symptoms and any changes during treatment. So you always, always, always want to communicate concerns about cardiac symptoms to the supervising PT and the physician immediately. So the other thing that I always ask patients if they say, oh, I have this or that, and I say, have you been cleared by your doctor for exercise? I just want to know. It's important. So arrhythmias can range from harmless to way different from harmless, life-threatening. So if you understand the difference, then helps you provide better patient care, better, safer patient care. So generally benign premature contractions in healthy people or bradycardia in athletes, um, or the premature ventricular contraction in young active individuals. And it's usually just a one or a two. It doesn't go on for minutes. Potentially serious atrial fibrillation and atrial flutter because there's that heart failure and stroke risk, and the WPW syndrome, which we didn't talk much about. It's okay. Life-threatening ventricular fibrillation is the most dangerous cardiac arrhythmia. Sustained ventricular tachycardia isn't good either. And severe bradycardia symptoms because you're just not getting enough blood out to your system, including your heart. So if I ask you on a test what's the most dangerous arrhythmia, you're going to say ventricular fibrillation, just so you know. Key takeaways, know the red flags. Use rate of perceived exertion to monitor exertion when appropriate. Monitor the patient's symptoms, not just their numbers. So taking vitals is one thing, but are they pale? Are they short of breath? Are they reporting any kind of nausea or indigestion or anything like that? And communicate any concerns you have promptly. Don't just wait and see what happens. Um, know your emergency protocols. Know where your AED is.